Welcome to This Week in Urology. This week we're covering 10 notable papers spanning benign prostatic obstruction and the surgical management of the prostate, advanced prostate cancer risk stratification and therapy, and a cluster of studies on peri-operative practice, imaging, antibiotics, opioids, and even remote robotic surgery. Let's dive in. We start with benign prostatic obstruction, where European Urology Focus publishes the one-year results of the VAPEUR randomized trial from Vincendo and colleagues, comparing Rezūm water vapor thermal therapy against combination pharmacotherapy with an alpha blocker plus a 5-alpha reductase inhibitor. This was a pragmatic multicenter trial in 151 sexually active men with symptomatic obstruction. At 1 year, symptom scores improved by roughly 11 points with water vapor therapy versus about 6 points with drugs, a difference of just under 5 points on the International Prostate Symptom Score, and quality of life improvement also favored the procedure. Sexual function score stayed essentially flat in both arms, and importantly, superiority for preserving sexual function was not demonstrated once missing data were accounted for, so that particular selling point remains unproven. Surgical retreatment was uncommon after vapor therapy, around 1% versus 9% with medication, though the vapor arm had more men going back onto drugs, and the combined retreatment endpoint did not reach statistical significance. The trade-off is adverse events, 40% with the procedure versus 28% with pharmacotherapy, and serious adverse events in about 1 in 8 men treated with vapor therapy, mostly procedure-related, and mostly resolved by a year. So the honest framing for a patient is better symptom relief and fewer trips to the operating theater later, at the cost of a higher early complication burden. Staying with the prostate but moving to the acute setting, World Journal of Urology reports a single-surgeon series from Peterson and colleagues of 24 emergency holmium laser enucleations performed as an inpatient for refractory hematuria. These were not easy cases. Median enucleated volume was 156 grams. Several patients had already failed cystoscopic fulguration during the same admission, and 11 had prior prostate interventions, including transurethral resection, photoselective vaporization, or artery embolization. 3/4 of patients passed avoiding trial on day 1, all were catheter-free at 3 months, and none required a further procedure, though 10 patients needed transfusion. It is retrospective and it reflects one experienced enucleator's hands, but it makes a reasonable case that definitive enucleation, rather than repeated clot evacuation, is the way out of intractable prostatic bleeding. Alongside that, European Urology Focus carries a provocative opinion piece from Sekula and colleagues, asking whether we should still be sending transurethral resection chips for histology at all. Their argument is that incidental cancer found in resection specimens is usually low-grade, transition zone tumors behave more favorably than peripheral zone disease, and routine processing is expensive and generates anxiety and follow-up that many men do not need. They stop short of recommending abandonment, instead calling for formal evaluation of a risk-adapted strategy in men with low preoperative suspicion. Worth flagging as a coming debate rather than a change to make tomorrow. Turning to advanced prostate cancer, World Journal of Urology publishes a post-hoc analysis of the Titan trial by Hori and colleagues, testing whether combining the CHAARTED volume criteria with the latitude risk criteria sharpens prognosis in metastatic castration-sensitive disease. Across just over 1,000 patients, the integrated classification into double low, intermediate and double high groups gave modestly better discrimination for overall survival than either system alone. Apalutamide improved survival across most subgroups, but in the double low group with synchronous metastasis there was no clear benefit, and the authors are appropriately cautious, noting very wide confidence bounds and calling this exploratory and in need of prospective validation. I would not use it to withhold intensification today, but it does point at a genuinely low-risk subgroup where the absolute gain may be small. Complementing that, European Urology Focus offers a practical consultation guide to PSMA-targeted radioligand therapy from McKenzie and colleagues. The interesting content is beyond the standard 6 cycles. Adaptive approaches including dose escalation or fractionation based on tumor volume, pausing treatment in exceptional responders, and retreating at relapse. It is a review, not new evidence, but it is a useful framework for the conversation you will increasingly be having in clinic. 3 papers this week deal with how we stage, operate, and prescribe. In BJU International, Valasila and colleagues report a systematic review and meta-analysis of fluorodeoxyglucose, PET-CT, for inguinal and pelvic nodal staging in penile squamous cell carcinoma, pooling 8 studies for the quantitative analysis. Sensitivity and specificity both sat around 85%, but the negative likelihood ratio of 0.25 is the number that matters clinically. A negative scan does not reliably exclude nodal disease. The practical message is that PET-CT is a confirmatory test, and in clinically node-negative men it does not replace surgical staging of the groin. Also in BJU International, Dinaire and colleagues describe a prospective pilot of telesurgical robot-assisted radical prostatectomy between two Belgian institutions. 10 remote cases matched against 10 contemporaneous on-site procedures. All 10 remote operations were completed without intraoperative adverse events and without local takeover, with median operative time around 155 minutes, mean network latency near 11 milliseconds, and one transient connection interruption that had no clinical consequence. Pathological and early functional outcomes fell within the range of the on-site comparison group. 20 patients is a feasibility signal, not evidence of equivalence, but it establishes the safety framework that larger trials will need. And BJU International also publishes a Delphi consensus from Lowry and colleagues on urological issues in masculinizing genital surgery, with 27 experienced gender-affirming surgeons reaching agreement on 75 of 83 statements. They declined to set an upper age limit for metoidioplasty or phalloplasty, but identified body mass index above about 25, diabetes, smoking and cardiovascular disease as relevant risk factors, with a Charlson comorbidity index of 3 or more a relative contraindication to phalloplasty, though not to metoidioplasty. For urethral complications, they favored staged reconstruction at a 6-month interval, with perineostomy considered in high-risk patients. No consensus was reached on suspending testosterone peri-operatively, an open question. Finally, 2 studies in urology challenge reflexive prescribing habits. Neiman and colleagues reviewed 435 children undergoing pyeloplasty at 2 pediatric centers and found post-operative urinary tract infection in just under 1 in 5. Drainage configuration was the dominant driver, about 15% with an internal double-J stent alone, rising to roughly 27% with an externalized stent, and 35% with a combined internal stent plus nephrostomy. And both externalized configurations remained independent risk factors after adjustment. Pelvic reduction was protective. Crucially, discharge antibiotic prophylaxis given to about 4 in 10 children showed no association with infection in any drainage subgroup. The parallel finding comes from Hoang and colleagues, who analyzed more than 12,000 outpatient urological operations at a single institution. About a third of patients went home with an opioid prescription, and those patients had roughly double the odds of an opioid refill in the first month, with elevated odds persisting out to 90 days. Independent of opioid naive status, recovery room opioid use, pain score at discharge, or procedure type. It is retrospective and residual confounding is possible, but the direction is consistent, just in case prescribing appears to create demand rather than meet it. If you only have time for one paper this week, make it the VAPEUR randomized trial in European urology focus. It is the first pragmatic head-to-head randomized comparison of water vapor thermal therapy against the medical regimen most of our patients are actually on. And it gives you real numbers for both benefit and harm to put on the table in clinic. Here are the key takeaways from this week in urology. Water vapor thermal therapy beat combination drug therapy on symptoms and quality of life at 1 year, but with more early adverse events and unproven superiority for sexual function. Emergency holmium enucleation looks like a durable solution for refractory prostatic hematuria in experienced hands. In metastatic castration-sensitive disease, combining volume and risk criteria refines prognosis, and the lowest risk synchronous group may derive less benefit from intensification, exploratory, and not yet actionable. In negative PET-CT does not clear the groin in penile cancer. And 2 papers converge on the same lesson. After pediatric pyeloplasty, choose your drain rather than reaching for prophylactic antibiotics, and after outpatient urological surgery, stop writing the just-in-case opioid script. That's your roundup for this week in urology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And a quick rating on Apple Podcasts or Spotify helps other physicians discover the show. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.